We're also so honored to have the American Congress of Obstetricians and Gynecologists with us today to share their perspective, and we're joined now by Mallory Schwarz, Federal Affairs Manager, to hear more about OBGYN workforce challenges and policy solutions. Mallory?
Thank you so much. Again, my name is Mallory Schwarz, and I am a member of the Federal Affairs team here at the American Congress of OBGYNs, or ACOG. Let my slides get up here. Great. Thanks again to AMTIP and NICM for all of their work in arranging this webinar and a great lineup of speakers. Definitely agree with what Dr. Lowe said. Collaboration. Today I'm going to address the OBGYN physician workforce and maternity care shortages with a specific focus on state and federal policy solutions. ACOG is the nation's leading group of physicians providing health care for women with more than 58,000 members. ACOG strongly advocates for quality health care for women, maintains the highest standards of clinical practice and continuing education of its members, promotes patient education, and increases awareness among its members and the public of the changing issues facing women's health care. These 58,000 members represent about 95% of all OBGYNs in the U.S. Health professional shortages threaten women's ability to access timely maternity care, which can have a devastating effect for women and their families. Every year, 1 million babies are born to mothers who did not receive adequate prenatal care. Without this prenatal care, babies are 3 times more likely to be low birth weight and 5 times more likely to die. This is devastating, but it's also costly for families as well as state and federal government. The average cost of medical care for a premature or low birth weight baby is $49,000 versus the cost of newborns without complications, which is only $4,500. Nearly half of women of reproductive age, which is 15 to 44, consider their OBGYN to be their regular physician. Yet there are major pockets of the U.S. where women do not have this access to needed OBGYN care. 49% of counties lack a single OBGYN. As you can see, these are in most states, but especially in the Midwest, the South, and the Mountain West. 9.5 million women live in these counties. Significant health disparities exist between rural and urban women. Rural women have less access to health care than urban women and experience poor health outcomes. The ratio of OBGYNs per 10,000 women is highest in metropolitan areas and decreases in less populated and rural counties. In some rural areas, family physicians provide 100% of obstetric care. That said, practice data does show that obstetric services provided by family physicians, as Dr. Lowe mentioned, is decreasing, and now only 19.2% provide routine deliveries. Access to specialty women's care, like vaginal birth after a C-section or VBAC, and abortion are also a significant concern. Right now, 87% of U.S. counties had no abortion. In 2008, 87% of U.S. counties had no abortion provider, and 35% of reproductive age women lived in these counties. To be sure, OBGYN shortages vary across urban areas as well. Metropolitan areas with older OBGYNs and higher workloads are at greater risk of these shortages. This map shows drive times to hospitals with maternity centers. Drive times to maternity centers vary across the U.S., with the longest drive times, again, in the West. Around the country, more than half of women in rural communities live over 30 minutes away from a hospital that offers perinatal services and appropriate care. Changes in the OBGYN workforce have broad implications on healthcare delivery for women. Dr. Lowe touched on a little bit of this in her presentation. ACOG projects an OBGYN shortage of 18% by 2030. In these next few slides, I'll highlight some trends and challenges facing the OBGYN workforce. This is by no means an exhaustive list, but I'll try to hit the main points. There's a decreased number of residency graduates relative to the population of women. In 2016, the number of ACOG fellows per 10,000 women of reproductive age was 5.5, which is down from 6.2 in 2008. Meanwhile, the female population is expected to increase 36% by 2050. Concerns about physician shortages in the 1960s first resulted in changes to graduate medical education funding through the passage of Medicare and Medicaid. However, as Dr. Lowe's slides indicated as well, medical school enrollment has only increased minimally over the past 30 years. An increase in the number of residency slots in obstetrics and gynecology funded by Medicare would help accommodate the additional graduates and the increase in women seeking care. But we need increased federal funding to ensure that there's sufficient residency positions to meet the growing demand. Physician practice patterns are also changing. The physician workforce is aging, and the average number of work hours is declining compared to historic levels, with a large number of OBGYNs now nearing retirement. Younger physicians are more interested in work flexibility and meeting personal family obligations. Physicians under 35 report a desire to work fewer hours. Also, more physicians are employed than in the past. Only 53% currently own their own practices, compared to over 60% in 2008, just about 10 years ago. There's also been a significant change in the gender distribution of OBGYNs. Women represent nearly one-half of all students entering med school and residency, but for OBGYN, the 2016 residency class was 83% female. Female OBGYNs are more likely to keep part-time schedules in order to balance career and family needs. However, something interesting to note, female OBGYNs are less likely to practice in rural areas than male OBGYNs, but OBGYN has the highest proportion of underrepresented minorities of all other specialties, and underrepresented minority OBGYNs are more likely than white or Asian OBGYNs to practice in federally funded underserved areas or high poverty areas. Finally, on this slide, the cost of professional liability insurance has the greatest financial impact on an OBGYN practice. Over 80% of OBGYNs surveyed report rising medical liability insurance costs as a serious concern, and nearly two-thirds of OBGYNs over 50 report retiring early, at least in part due to rising medical premiums. Finally, women's health delivery is moving towards team-based care. The OBGYN workforce must take into account alternatives to accommodate increasing numbers of patients and improve effectiveness in delivering health care. A shift to more collaborative, team-based care will improve access to health services while maintaining quality satisfaction. Qualified healthcare professionals working in concert with physicians will help meet this unmet need while reducing the cost of care. ACOG enthusiastically supports collaborative team practice and team-based care, including models such as patient-centered medical homes. ACOG supports models that use every member of the team to the full capacity of their training and skills, as our colleagues at the Nurse Midwives mentioned. Additionally, team-based care meets the Institute of Medicine's expectations of healthcare and the Institute for Healthcare's triple aims of improving the experience of individuals and families, improving the health of populations, and lowering per capita costs. Currently, more than half of all OBGYNs employ non-physician healthcare professionals, including nurse practitioners, nurse midwives, certified midwives, and physician assistants. While health reform is not the looming threat it has been since the start of this year, 2017, at ACOG we remain cautious about the future and the ongoing reform efforts in Congress. Talk a little bit about what it was like pre-ACA. Before the Affordable Care Act, 13% of all pregnant women were uninsured. Health coverage for about 39.5 million insured women was subject to lifetime coverage limits, causing many to lose coverage mid-treatment or mid-pregnancy. Nearly a third of pregnant women lacked health insurance or was forced to move between different types of coverage around the time of pregnancy. Only 12% of policies on the individual market covered maternity care at all, and 1 in 5 women of childbearing age was uninsured. Additionally, insurance companies could impose waiting periods for up to a year, but often conveniently at the 9-month mark before they would allow a woman to use maternity care coverage. And due to gender rating, a 25-year-old could find herself paying over 80% more than a man for identical coverage. While not perfect, the ACA has provided women with landmark health gains. 8.7 million women gained maternity services under the ACA. Over 55 million women gained access to preventative services with full coverage and no cost sharing. The prohibition on pre-existing conditions ensured that 65 million women with conditions, including a C-section or a history of domestic violence, could not be denied coverage. And the prohibition on gender rating saved approximately $1 billion in annual costs. The ACA also ensured direct access to OBGYN care, which prior to the ACA, I believe was only in 22 states and was a state by state. So how do we address these challenges on the state and federal level? An efficient, high-quality women's health care system depends on the right number of physicians and other healthcare providers in the right locations at the right time. State and local efforts should include Medicaid expansion to ensure continuous coverage for low-income women. There is concern that with numbers of Medicaid waivers, we're going to see a decrease in the number of newly insured women. Additionally, the addition of a rural training track in medical residency programs. Currently, 24 family medicine residency programs have incorporated a rural training track. Graduates of these programs are 2 to 3 times more likely to practice in rural areas than graduates of family medicine residencies overall. The majority of those physicians initially selecting rural sites tend to remain in rural locations for up to 2 years or more after graduation. Next bullet is the implementation of team-based care models, as we've discussed, to achieve quality, efficiency, and value in the evolving healthcare system. Organizations across all specialties should develop team-based care. Team-based care can respond to emerging demands and reduce undue burdens on practitioners. Uniform licensure standards across all states. State licensure and scope of practice laws, as Dr. Lowe mentioned also, should support common minimum education training and accreditation standards. In order to improve provider collaboration and systems integration, licensure laws should ensure a level of consistency in the credentialing of practitioners who provide health services and should also recognize that the skills, training, clinical experience, and demonstrated competencies of physicians, nurses, physician assistants, midwives, and other healthcare professionals are not interchangeable. Accreditation, education, and professional certification should be a precondition of licensure in all states. And finally, the development of an integrated maternity care system. ACOG calls for system-level improvements in maternity care, including implementation of a new uniform classification system for how risk-appropriate maternal care is delivered across the U.S. and new regional criteria for facilities. And again, as Dr. Lowe mentioned, we are happy to be working with many provider partners, including the American College of Nurse Midwives in some of these developments. On the federal level, ACOG focuses on possible policy solutions that address 4 primary areas: increased residency slots for obstetrics and gynecology, medical liability reform, data collection in areas of greatest need, and ensuring that residents are placed in health professional shortage areas. Increasing funding for graduate medical education is essential to address the projected physician shortfall. An increase in the number of residency slots for obstetrics and gynecology funded by Medicare would help accommodate additional medical school graduates. Without sufficient funding, some residency programs may decrease the number of residency positions they're willing to hold. There are a couple bills right now. The Teaching Center Reauthorization Bill, the Teaching Health Center Graduate Medical Education Extension Act of 2017 reauthorizes the Teaching Health Center program. Teaching health centers train physicians in community-based primary care settings, such as federally qualified health centers, and primarily serves underserved patients. This legislation was just reintroduced in the House and Senate this summer, and it would reauthorize the Teaching Health Center Graduate Medical Education program for 3 years. It would also allow for the expansion of new programs within current health centers and the creation of new centers to meet the growing need for community health services. There is another bill, the Training Tomorrow's Doctors Today Act. It has not yet been reintroduced in 2017, but this legislation would fund 15,000 additional residency positions through Medicare, and we continue to advocate for it. Under medical liability reform, as I mentioned, raising premiums contribute to early retirement among OBGYNs. There are many number of currently introduced medical liability reform bills the ACOG supports in the current Congress. I'll mention just a few right now. The Protecting Access to Care Act passed the House earlier this year and would institute a number of reforms, including a $250,000 cap on non-economic damages. The Access Act, or the Accessible Care by Curbing Excessive Lawsuits Act, would encourage speedy claim resolution for both patients and physicians to ensure they aren't wrapped up in lawsuits for more than 3 years. And the Good Samaritan Health Professionals Act, which would allow physicians to practice across state lines or licensure to transfer across state lines in the case of national disasters. For our next two bullets, data collection and health professional shortage areas, before we take a look at the legislative solution, I'm going to quickly discuss health professional shortage areas. HRSA develops shortage designation criteria to determine whether a geographic area, population group, or facility is a health professional shortage area, or a HPSA. The National Health Service Corps was created in 1972 to help fill provider shortages, and does this by providing scholarships and loan repayments in exchange for service. Those providers are placed in health professional shortage areas. Currently, over 50,000 providers, including OBGYNs, have participated, and over almost 11,000 providers serve more than 11 million Americans at over 5,000 sites. As it stands today, there are shortage area designations for primary care, dental care, and mental health care, but not for maternity care. The midwives and OBGYNs that currently participate in the program OBGYNs qualify as primary care providers. As more than 6 in 10 patients who access care through a women's health center do consider the women's health provider their main source of care. However, as we'll see in the next slides, there are unique benefits to having maternity care a specific designation. The Improving Access to Maternity Care Act. Currently, OBGYNs in the National Health Service Corps are sent to sites that may not have high maternity care needs and we do not know because there's no specific data collected to help identify maternity care specific shortages and identify areas with these needs. This legislation would require HRSA to designate maternity health professional shortage areas based on population needs and it would target maternity care resources where they're most needed, helping to ensure healthier pregnancies and healthier babies. The National Health Service Corps has a really strong retention rate, which will help ensure access to health care in underserved areas over time. Of ACOG fellows, approximately half will practice in the same state they trained, and two-thirds will practice in the state they attended medical school or undertook residency. Meanwhile, in the National Health Service Corps, they found that 82% of National Health Service Corps clinicians continue to practice in underserved communities in the short term. That's up to 1 year post-completion. And almost 60% of these clinicians will continue to practice in underserved areas 10 years later, which is a really strong retention rate. The Improving Access to Maternity Care Act was first introduced in 2014. A hearing was held in December 2015, and the bill passed last fall, November 2016. When it was reintroduced in January of this year, it was advanced really quickly, and we now are calling on the Senate to support this legislation and move it forward. ACOG and ACA&M worked closely on this legislation and continue to. From a joint press release on the passing of this bill in January of this year, this legislation addresses ACOG and ACA&M's long-standing priority to ensure every woman has safe and timely access to care from a women's health care provider, and seeks to determine areas throughout the country that are experiencing a significant shortage of full-scope maternity care professionals, including OBGYNs, certified nurse midwives, and certified midwives. ACA&M and ACOG continue to work on this legislation. ACOG has a petition available on our website. I didn't put it here, but it's acog.org/action or acog.org/action that does say as an OBGYN, but it is editable, so we encourage anyone to check it out and contact your senators and help us advance this legislation.